Hi everybody, it's Deb here again, and we're doing day 3 of EULAR debriefs. My session that I saw was on cardiovascular comorbidities, and it was really interesting and very technical. So I'm going to do a lot of descriptions with what these long names and terms mean. Also, if you have questions about this, please ask in the Elevated Experience platform on our Slack channel so I can actually answer them in real time. So they talk about the causes of death in RA are infection related, GI illness related, as well as cardiovascular disease. They say that's a really important piece because an RA patient is up to 2-fold increased risk of cardiovascular risk of death. And that's pretty daunting and scary. And they also talked about, in the past, they talked about a decrease in the life expectancy of an RA patient being 10 to 15 years. Again, big clips on our lifespan, but that has changed. So stay tuned to the end when we talk about our conclusions. They talked about there is cardiovascular disease and RA. What are your risks that are associated with that? So they talk about cardiovascular risk. You have a double prevalence of cardiovascular disease and the doubled incidence of cardiovascular disease. And they say this actually is its own independent risk factor for cardiovascular issues. Daunting. But they talk about nowadays there's still 30 to 70% increased cardiovascular risk in RA patients, mainly due to the risk factors associated with that. They talked a lot about the use of colchicine. That was just approved, whether a year or two ago. Don't quote me on that. I forget exactly when it was FDA approved for the treatment of cardiovascular disease, but they say that it's very inexpensive and it's 0.5 milligrams and used on a daily basis. It will decrease the incidence of cardiovascular death and with stroke by 30%. That's amazing. That is really amazing. They talked about acute myocardial infarction. What does that mean? That's a heart attack. They talked about coronary calcification. There's a lot of different tests that you can actually measure the amount of calcification you have in your coronary arteries, and there are things that play into that. It's plaque. You've heard that word before, but they talk about plaque rupture. Plaque can actually be in your heart valve or heart vessel, and it can rupture, which means it breaks off, which can lead to a heart attack or a stroke, depending on where it breaks off in your heart or your lungs or wherever. So some plaque study conclusions. They talked about the patient who is an RA patient has an increased prevalence of severity of all types of coronary plaque, and you're at an increased risk of adverse cardiac events. So we need to target the disease activity, which might help decrease the risk of cardiovascular incidents in our lifetime. Heart failure is another major issue. They say that patients with RA tend to have almost a doubled incidence of heart failure versus the general population. Tends to be more in women. And they talk about why does this happen in an RA patient? They say cardiac disease increases the prevalence of cardiac risk, which I had mentioned before, but the chronic inflammatory process in our body that's happening is an increased risk in itself. I can have inflammation in my body because I have RA, but that also means I have inflammation in my heart. So it's an ongoing issue that we need to stay on top of. They talked about the European Medicines Agency, which is very similar to our FDA federal type of use of medications. They say that the medications should be used in patients only if there's no other suitable medications that are available, that they're age 65 and above, and increased risk of cardiovascular problems being heart attack or stroke. And this is in relation to JAK inhibitors. JAK inhibitors should be used with caution in patients that have these higher risk factors and risk factors of deep venous thromboembolism, which is venous, like in your veins, that you have a blood clot in your vein. Let's see. They talk about, another major piece that they were talking about was we need to have cardiovascular risk management, and that it's necessary, not just optional, but it's necessary, and use controlling medications that will help with issues like hypertension, and also make sure you're managing the blood pressure, cholesterol, also looking at the best type of foods to eat, being active, managing depression and diabetes. And the conclusions that they came to is cardiovascular risk in inflammatory RMDs is increased, and they also talk about a decreased life expectancy. In the old days, they said that it was 10 to 15 years chopped off, but now we're presently at 1 to 3 years, which is a whole lot better in my mind. Major causes in inflammation is equal to accelerated atherosclerosis. So again, plaque building up in our heart. There are independent risk factors for cardiovascular disease, and past it was at 30%, now we're presently at 70%. So cardiovascular risk management is got to happen immediately. And that was the focus that this gentleman said, and said that we really need to work with this. They talked about the colchicine. They said methotrexate doesn't really necessarily have an effect on the general population. And they talked about stopping the tapering of anti-rheumatic therapies, that if you do that, if you try to taper from the medications that we use for our diseases, that the increased risk of cardiovascular risk is going to go up. And let's see, as far as the research agenda, what is on the forefront? They say that we have to have translational research and to stop looking at tapering and stopping biologics in some patients, because it's going to have more events of thrombosis and heart attacks and things like that. So those are the types of things that they want to get out there sooner and get studies going. And actually they talk about international studies. So overall, this is something that we all have to look at, and I was really glad to learn a lot more, but we need to really pay attention to what's going on with our cardiovascular